Is it true that rock rocks and sucks sucks? We'll check it out today on MAJC. All right, hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester from the Overrun here. Today, Danny, we're going to talk about a follow-up, actually, to a previous study that came out in 2019. So this study came out of the Annals of Emergency Medicine. This is coming out of Vanderbilt, and there's a bunch of other studies, or a bunch of other participants here. This is for the Critical Care Research Group, which they spend time looking at critical care interventions. They've done a lot of work on intubation. So the backstory to this, in 2019, there was a paper that came out of France that showed that Rocuronium was non-inferior to Succinylcholine as far as intubation is concerned. Now, I'm not a huge fan of that terminology, right? Non-inferior sounds like something weird. But what the 2019 study was looking to do was it was looking to establish, is one better than the other? So it turns out that Rocuronium in 2019 was just as good as Succinylcholine. What was done in this study is they looked at the difference between being able to pass a tube in patients that receive Succinylcholine and Rocuronium. So, Danny, let's talk about some of our ideas in the field, maybe some preconceived notions, then we'll get into the meat of this paper.
You know, this is really a tough topic because it's kind of the cool kid thing, right? You know, everybody wants to say rock, sucks, sucks. I read a couple abstracts of papers and, you know, I'm an expert on depolarizing, non-depolarizing paralytics. You know, the non-inferior thing is kind of funny to me because it's like, okay, this doesn't suck less than the other option we have, but that's what we have, Fred, right?
Right, yeah. We don't have a perfect solution, but maybe we have a good one.
So this kind of goes into meta-analysis world. Like we're looking at, we're studying studies. And this research group looked at two major studies and they got about 2,400 people enrolled in it, which was good. A lot more people got Rocuronium than Succinylcholine, which if you're reading the abstract, you're going to notice that people with Rocuronium had more complications and more problems than Succinylcholine. If you're just reading the abstract or you're not really looking at the paper, there's a potential here that you could misread this, right?
Oh, absolutely. So the way that this is phrased, and the biggest thing to look at, and one of the problems that people fall into, is they tend to just read the abstract of the study. So in this study, we look here at the results, right? There are 2,440 patients that were randomized into the trial data sets. 2,339 were included in the analysis. Also a great number. 475 patients received Succs and 1,864 patients received Rocuronium. So the way that that's adjusted in data analysis is usually the patients are stratified, which is that because we have essentially, 3 times as many patients received Roc as did Succs, we do statistical analysis to stratify what that would look like if they were 1-to-1 even, right? Because if I have 1,000 patients that get Rocuronium, I have 500 patients that get Succs, I'm going to have more outcomes to my Rocuronium patients, right?
Because it's like a weighted average, right?
Right, exactly. So when you see things on here where here we see severe complications occurred in 67% of patients who received Succs, that's 14%, and 456 patients who received Roc, that's 24.5%. But the problem with that, when you adjust that, right, here's our odds ratio of 0.88. So we had more patients who had problems that received Roc than received Succs, but more patients received Rocs than received Succs. So essentially
Ed, Ed, tell me about an odds ratio. If I'm just picking up the show for the first time and we're talking all this research stuff, what the hell is an odds ratio?
So an odds ratio is just a stat that looks at the strength of association between the two events, where you can convince yourself, or the data can convince you, that this intervention or reducing this intervention actually caused this change. So when we look at it here, right, 0.88, again, and you don't necessarily, it depends on the data set of where you want your odds ratio to be, but essentially this odds ratio of 0.88 is showing that there's little deviance between the Succinylcholine and the Rocuronium. So when you're looking at a data set, if the simple question is which is better for facilitating intubation, this paper essentially suggests that they're equally effective. So Succinylcholine, Rocuronium, you probably can give either one. Now, part of the reason I think that this study had more Rocuronium than Succs is because for a long time we've been saying that Rocuronium is a better adjunct than succinylcholine is. So looking through here, and we get to this editor's capsule. One of the things I really love about what Annals does is that they do these capsule summaries. So it kind of gives you an idea, right? Roc and Succs are two of the dominant intubation drugs. They looked at what they do. Despite the large number of patients limited by study design, no clear advantage existed between either of these paralytics during emergency intubations. So if you're reading Annals specifically, and you don't get what you want out of this abstract, Annals is very good at doing a capsule summary that can kind of give you all of the ideas and all of the big points out of this study.
Yeah.
So, and then we go down here. I think it's great. And then here, so the two studies they're looking at were the device trial and the pre-oxy trial. They were both published a while ago. But as they compared it here, again, median age, 51. They had females established. They looked at different races, all these other kind of things. They also mentioned etomidate, ketamine, propofol for induction. Etomidate, still one of the preeminent drugs for sedation in induction. Whether or not ketamine would make more of a difference, we don't really know. We know that I tend to prefer ketamine over etomidate. But then also down here, we have different adjuncts that were used, a bougie, an ET tube with a stylet, or neither. So here, we have Succs and Roc intubated with stylets. Here we have bougies. Again, probably not enough use of bougies for, if we're looking for optimal outcomes, but we had some of it. And then here's a really good graph that shows successful intubation. And again, here you see it's essentially 81 to 79%. So the differences between the Rocuronium group and the Succinylcholine group are minimal, at least in this data set. So something that we discuss on the show a lot is if you've seen one data set, you've seen one data set. Now, here, it seems like we're coming up to the point where we've kind of seen two data sets that seem to support this, whether you want to call it a bias or whatever that we have. But now it seems like it doesn't really matter which paralytic we use. What's exciting to me about that is that now maybe we can stop having this facile argument over what paralytic to use and start actually having a conversation of how to better facilitate intubation in these patients.
Amen. I love that. And that was going to lead into exactly what I said. I remember at the New Jersey conference that we just talked about in the previous block, I was sitting next to a paramedic who's getting RSI in their program for the first time. I remember being that, nervous medic in 2007 when this started in our state. And then I bought into the foam med stuff, Roc, Succs. And I've got to be honest, I use succinylcholine a lot more than you would think I do. I found that the danger of malignant hyperthermia, the danger of potassium, unless it's a very limited population of patients, you just don't see it pre-hospital. Does that mean that you can completely discount it? No. If you're going to be a good clinician, you got to know what you're playing with, right? But the fact is, this stuff doesn't happen as much as everybody thinks it does. And this study kind of reinforces pretty much each paralytic is good. They do their own things. Now, personally, I'm just going to go on a soapbox here. I think in the pre-hospital world, I'm going to make an argument. It's a hot take, and feel free to slam me in the comments. Succinylcholine might be a better option for patients, in my opinion, because of the idea that it is a depolarizing blockade, and it lasts a lot longer than Rocuronium, which leads to that problem of patient handover. We get somebody into...
Roc is long lasting. Succs is short lasting.
Yeah, that's what I mean. It's shorter. Yeah. Did I say the other one?
You said longer.
No.
Okay.
It will last shorter, and that person, by the time I get them to the emergency department to transfer to the resus bed, they're out of paralysis, which means if they're light on their sedation package, if the doctor's late with writing that order, we don't have a paralyzed person who's aware of what's going on, who's aware they have a tube down their throat, and they can't do anything about it. Extremely traumatic, extremely nerve-wracking. It's bordering on cruelty. I know it happens sometime, unfortunately. We don't have a choice. But if we can avoid that, that's a good thing. I think Succs gives you a little bit more safer cushion.
So I'm not convinced that one is better than the other. And I have nothing but respect for having individual clinical practice. One of the things that I'm really pro is cognitive offloading. And one of the reasons that I would suggest Rocuronium in an algorithm is with succinylcholine, you have to worry, like obviously if a patient is a live burn patient, you're going to notice that, right? But what you're not going to notice is if your patients go into rhabdo or they have AKI or if they have, some sort of muscle breakdown that can be worsened by a depolarizing paralytic. That's really my only hang up. So operationally, yeah, succinylcholine has a half-life of 7 minutes. Great. Get it on board, get them intubated, get them sedated, off to the hospital. In the overwhelming amount of patients that we have, there's absolutely nothing wrong with that. As long as they have adequate sedation. That's why I say like ketamine, Succs, ketamine, or ketamine, rock ketamine, great. Get it out there. If you want to give fentanyl for pain management, go nuts. The reason that I tend to support rock in RSI a little bit more than Succs is, again, and I'm speaking in very broad strokes. Generally speaking, I think Rocuronium has less of an index of failure than succinylcholine does. So there's all these advantages that Succs might have over rock, right? A short half-life. Years ago, pre-hospital, we were taught like, oh, well, we carry Succs because if you miss the tube, then the patient will wake up. And my argument to that is if you have a patient that you don't think you can tube, you shouldn't be paralyzing them. If I have someone who, if I've gauged someone to be a difficult airway, I probably shouldn't be paralyzing them in the first place. So that argument's a little bit facile to me. So again, what's reassuring is looking at papers like this, is like, all right, we're doing the research, we're doing the work. Odds are you can probably give either paralytic and have just as good of an outcome. Now, what they don't look at in this data is they don't look at patient outcomes, right? It was really which drug allows for facilitation of intubation better, right? They didn't look at anything else downstream. So in a kind of, in isolation, right? In a vacuum, yeah, I'll give rock or Succs depending on the patient. It doesn't really matter. Their outcomes are the same. But we have to take this information and apply it to our patients that are out there, right? So if I have a patient who's been, you and I have had, it seems a rash of patients these past couple months of patients who have just been laying on the floor for 3 days. So
not a good
if they've been laying on the floor,
candidate.
exactly. If they've been down for 3 days, we don't want to give them Succs, right? That's someone who's going to get rocked. And I also worry that there's some concern that, what the patient's condition at the arrival to the ER is going to be, where like, oh, well, we can't do neuro checks on a patient who's been intubated and paralyzed. Okay, they're still breathing though. So, it's this hospital versus EMS conversation where our priorities are stabilizing and getting them to the hospital. I don't necessarily care what the hospital's preferences are. You know what I mean? Not to say that it's not something we should take into account. It's just in that moment, I have a patient who doesn't have an airway and I have to get them an airway. Do I care more about how I'm going to be able to facilitate intubating this person, or do I care about what the receiving physician is going to think when I get to the hospital? You know what I mean? Like it's that kind of debate.
Or the other side, do I want that patient safely transported with a first pass success without hypoxia, without hypotension? And if it takes 45 minutes to an hour to do a neuro check, I mean, we have the donut of truth. It's, I think there's an option to do that.
Always spin them in cat skin. Yep.
Always. But, I think it's an interesting clinical discussion about one agent or the other. Here's my advice is don't lock onto one as a specific rule. Just like accommodating ketamine. If your program if you're lucky enough like we are, where we get multiple paralytics, we have multiple induction agents, learn about them and tailor them to that patient presentation. There are people, listen, just like you, I love ketamine. I love that it does a lot of different things. I love that it's less vials. I think it lowers your cognitive load. But there's still a role for autonomy. And there are things that autonomy does very well that I might not want to give somebody ketamine for a variety of reasons. That head bleed with ICP and their blood pressure is 240 over 120.
Right.
I know ketamine's not going to do it that much, but at the same time, do I want to play that game? I want to be forward thinking. I want to be playing chess, not checkers. I'm going to go for autonomy.
Well, and that's kind of the thing, right? That's kind of why we do these journal clubs, right? Here's data that supports if an RSI is a 14-step process, Now we have information like, all right, on step 3, the data says I should do this, right? We haven't gotten the rest of it, but we know that on step 3, we can use either ROC or Succs, and that's pretty much, established until it's not in the data.
Sure.
But we do want to know what you guys think. Do we have a preference for Succs or ROC, or how are we RSIing out in the field? Let us know. Head on over to Overrun EMS and check out all the other stuff we have. We're also out on Spotify, Apple Podcasts, and YouTube. For the Monday Afternoon Journal Club, I'm Ed Bowder. He is Daniel Schwester, and we will see you next week.
Take care.